So at the stroke of 5:30, a warm welcome to all of you who are here, already logged in. And it's such a pleasure and we are very pleased that you're here. Well, a warm welcome again. Today, we are going to embark on our first international journal club through the Pediatric Anesthesia Committee of the WFSA. In other words, we are actually bridging continents, bridging time, so that we come across the cutting edge technology here, cutting edge research in pediatric anesthesia, so that we all elevate our pediatric anesthesia care to the patients that we give. Our topic for today is as follows, and for that, I am going to share my screen with you. And there is something very wonderful waiting for that. Give me a minute. Here we go. A question to all of you. Is my screen very clear and is my sound very clear? Fantastic. So welcome to the World Federation of Anesthesiologists. And do you all know that this is the 70th year of WFSA? Well, as I told you, we are here for a purpose. And this little kid is going to show you the purpose. Wait and watch. I love this video. A young gentleman goes off to work in the morning and is fed up and frustrated. And another one comes and helps him out. And now there is a saying which is going to come up. Watch it. Education opens the door. And that's what we all are here for. And that's what we are going to do for each other, as it were. So today's topic for Pediatric Anesthesia Journal Club is Fluid Strategies in Pediatric Anesthesia, Embracing New Horizons. Let's review recent papers. Don't you feel in pediatric anesthesia, fluid is something which has always remained a little enigmatic, as it were. And hence, this is our opening topic, you could say. It gives me immense pleasure first to share with you who I am. Well, I am Dr. Vrushali Ponde. I am from India, Mumbai, and I serve the WFSA as the Deputy Chair for the Pediatric Anesthesia Committee, and I am the program head for the Fellowship of Regional Anesthesia in Pediatrics. And I serve the Asian Society of Pediatric Anesthesia as the president, and that's all. Let me go ahead and share with you the housekeeping rules for today. Yes, please raise your hands if you have a question or a comment so that we know that you want to. Write questions in the chat box because time is always at a premium. So our faculty can even answer the questions in the chat box itself. Q&A question and answers for each research paper would be immediately after those papers so that we get your thoughts there and then. Complete the feedback form which you would be receiving. It's mandatory to generate the certificate. Certificate of attendance will be provided to participants who attend the full session and submit the feedback form. And of course, we would love to hear your feedback on what all other topics would you like for us to discuss in the journal club. Another pleasant responsibility I have is to introduce my dear friend, Serpil Ozgen. She is from Turkey. She is currently the Pediatric Committee Chair, WFSA. She is currently the President, ASPA, and she works in the Department of Anesthesia and Reanimation, University, Acıbadem, Istanbul. Our speaker today is Dr. Hee Soo Kim. She is a leading professor of anesthesiology and pain medicine at Seoul National University, specializing in pediatric anesthesia and pain management, focusing on pediatric neurosurgical anesthesia, and of course, her special interest is fluid management. Dr. Preeti Matthew, she is from India, Chandigarh. She is a professor. She works in the Department of Anesthesia and Intensive Care, PGIMER, Chandigarh, and her special interests are pediatric anesthesia, pediatric airway, and fluid management. That explains why both our speakers are here today. So I give it over to Preeti from here on, and her topic as well as all that she has spoken in it shall be given to you very shortly. So Preeti, over to you.
Thank you, Vrushali, for your kind words of introduction, and a good day to all of you.
Oh, sorry. Preeti, I'm going to stop my sharing so that you can start yours.
Okay.
Yes. Thanks, Preeti. We did hear what you said.
Thank you, Vrushali, for those kind words of introduction, and a very good day to all of you out there in the meeting to listen to this journal club. At the outset, I also thank the Pediatric Committee of WFSA for this opportunity to discuss one of my publications and work, which has influenced the way we manage our pediatric patients at our institution. This work is titled Goal-Directed Fluid Therapy Guided by Plethysmographic Variability Index, PVI in short, versus conventional liberal fluid administration in children during elective abdominal surgery, a randomized controlled trial. And this work was published in the Journal of Pediatric Surgery in 2023. Coming to why we did this study, as you all know, in our day-to-day practice, we are often faced with dilemmas in fluid management. Which fluid is best, how much is optimal, so on and so forth. So the focus for today's discussion would be how much is optimal. Now, if you look at the ERAS guidelines, which covers most of the major surgical procedures, it suggests to target euvolemia. And in adults, the guidelines clearly suggest to use a restrictive and or a goal-directed approach. When it comes to pediatric major surgical procedures, the guidelines are silent about using restrictive and or goal-directed approach, and the whole stress of targeting euvolemia revolves around minimizing the preoperative fasting, and there's no mention about how to go about it in the intraoperative phase. And if you look back, way back in 2014, this group from Thailand evaluated using restrictive approach in pediatric abdominal procedures and found that restrictive fluid regimens may not be applicable to children. Positive results in the adult world, which essentially the goal-directed approach essentially means to optimize organ perfusion and oxygenation based on clinical science and statistic or dynamic indices of fluid responsiveness. And we know from the adult world that the dynamic indices predict stroke volume much better than the static variables. And by static variables, I mean the conventional variables like heart rate, blood pressure, mean arterial blood pressure, urine output, and so on and so forth. When we look at the dynamic indices, it could be either pressure-based or volume-based indices. Pressure-based indices essentially are the systolic pressure variation or pulse pressure variation, and stroke volume variation is a flow-based index. And it kind of captures the cardiorespiratory interactions and to indicate what is the preload status or the stroke volume status of the patient. Now, when it comes to these dynamic indices, we have a non-invasive index, which is Plethysmography Variability Index, which is calculated from pulse oximetry. So the pulsatility index is the maximum and the minimum is subtracted, and it's divided by the maximum pulsatility index, and it's expressed as a percentage. Now, when we look at the PVI, what we already know is that the PVI has been validated as a reliable predictor of fluid responsiveness in children, in mechanically ventilated children. And in the adult world, we know that from the meta-analysis that using PVI-guided goal-directed fluid therapy, there's a significant reduction in the intraoperative fluid administration in both colorectal surgery and neurosurgery. Now, building on this, we proposed a hypothesis that a PVI-guided fluid regimen would achieve euvolemia with lesser intraoperative fluids than the conventional fluid therapy in pediatrics, and it would have a favorable outcome on the postoperative recovery. Now, this was tested in a clinical setting to compare, and we kind of focused on just the intraoperative goal-directed fluid therapy in elective bowel surgery in children. And the primary outcome that we evaluated was the amount as well as the rate of fluid or crystalloids infused intraoperatively. And we also looked at the secondary outcomes of intraoperative hemodynamics, any metabolic changes, especially serum lactate at the end of surgery, or postoperative laboratory parameters, hemoglobin, electrolytes, and creatinine. We also looked at the surgical outcome of recovery of bowel function after the surgery, and also duration of the postoperative hospital stay. Now, it was designed as a prospective randomized controlled trial in our tertiary care university hospital. We obtained all the necessary regulatory approvals and decided to randomize 44 children based on calculations. The children enrolled or randomized were in the age group of 6 months to 3 years of AS's physical status 1 or 2, and all who underwent elective open bowel surgery who required a standardized gut preparation. And the anticipated duration of surgery should be more than 60 minutes. Laparoscopic procedures, those with anemia or anticipated massive blood loss, those with cardiopulmonary disease or hepatorenal insufficiency were excluded from this randomized controlled trial. Now, this is a busy slide, but essentially tells us how exactly we manage fluids in our control arm, which is the conventional liberal fluid therapy group, and also in the study arm, which is the goal-directed fluid therapy group. So in the conventional group, in the control arm, we started how we normally do. We kind of, when the child arrives in the operating room, we started with the replacement for the fasting for whatever duration based on calculations, as well as maintenance. And also we ran the evaporative loss replacement during the procedure. And these calculations were based on what we know conventionally based on Holiday-Segar calculations of 4-to-1 rule. Now, if the blood pressure and the heart rate were normal, we would just continue the calculations and replace the fluids as we conventionally do, which is kind of liberal. And then if the mean arterial pressure was decreased by more than 20% of the baseline, or the heart rate rose more than 20% of the baseline, we would give 5 milligram per kilogram of boluses, which could be repeated every 10 minutes until the mean arterial pressure or the heart rate came back to within 20% of the baseline. And we would allow up to 25 mils per kilogram in 1 hour. And this hemodynamics would be, after every bolus, we would review the mean arterial pressure and heart rate. And we also had provision in case we need to administer, if we reached we limited it to 25 mils per kilogram in 1 hour. And in case we were reaching the limit, we had provision to add vasoconstrictor phenylephrine to the fluid management. In our study arm, which was the goal-directed fluid therapy, the target PVI, we took PVI as a goal-directed target, and we targeted a PVI of less than 13% as normal. So when the child arrives in the operating, we would just start with maintenance fluids, which would be based on Holiday-Segar 4-to-1 rule, just the maintenance for that particular hour. And then we would also look at the mean arterial pressure and the PVI. In case the mean arterial pressure was outside the 20% of the baseline, or the PVI was more than 13%, we would administer 5 mils per kilogram of fluid bolus, and which would be repeated every 10 minutes if the MAP remained outside 20% normal, or the PVI continued to be more than 30%. And in this arm also, it was standardized similar to the control arm. We would allow only up to 25 mils per kilogram of crystalloids in 1 hour. And in case it exceeded, in case the mean arterial pressure or the PVI was not within the desired target, we would add phenylephrine to the fluid regimen. And throughout the procedure, we ensured adequate anesthetic depth as well as analgesia. Coming to the remaining part of the standard anesthesia protocol, lactated ringer solution was employed in both the groups. And in case the blood loss exceeded the maximum allowable blood loss, it was treated with packed red cell transfusion. Anesthetic technique was standardized across between both the groups because it was randomized, but not blinded. We used fentanyl 1 micrograms per kilogram initially for analgesia and used muscle relaxation for endotracheal anesthesia. And all the patients were given epidural analgesia either with caudal or lumbar epidural, and there was provisions for a standardized rescue fentanyl administration in case the attending anesthesiologist perceived that the patient is having pain. And the monitoring was standardized across both the groups. And what we found, we randomized 44 patients, of which 42 were analyzed because 2 patients in the control arm had deviation from protocol. So we had 20 patients from the control arm and 22 patients from the study arm. For the data from these patients were available for analysis. What did we find? The age group, the average age of the children was comparable, about 16 months, 1.5 years approximately. Their average weight was also comparable. And the remaining, the duration pre-op fasting and the gut irrigation fluid, as well as IV fluids were all comparable. The most of the procedures, predominantly the surgical procedures that the enrolled children had were either stomach closure or PSA-RP. A few of them had Duhamel's pull-through or abdominal perineal pull-through. The hemodynamic parameters at the baseline as well as laboratory parameters were also comparable and similar. I want you to take a note of this hemoglobin, which is the starting hemoglobin was about 10 gram per deciliter in both the groups. Now, when we came to looking at how much fluids were infused in both the groups, we found that in the conventional arm, we administered about 37 mils per kilogram during the procedure, whereas in the GDFT group, that is the PVI group, it was only 24, which was statistically significantly different and less. And if you calculate the rate of fluid administration, it amounted to 18 mils per kilogram per hour in the liberal group, as compared to 11 mils per kilogram per hour in the PVI group. And the average PVI between the two groups also was significantly different. The urine output was comparable. The blood loss, as well as the number of patients who received blood transfusion were also similar in both the groups. This gives you an idea of how the heart rate fared and the mean arterial pressure fared in both the groups. They were comparable, hemodynamically similar. The PVI was higher to start with in the goal-directed group, but it kind of settled in about 30 minutes to 1 hour. The number of the analgesic requirements in terms of number of patients who required rescue and fentanyl, as well as the total fentanyl that was administered, was similar in both the groups. Coming to the outcomes, the surgical outcomes, we found that the return of bowel function was significantly earlier in the goal-directed group, fluid therapy group. This is about 36 hours because by post-update 2, most of them had their bowel function returned, whereas it was significantly delayed in the conventional fluid therapy group. However, the duration of postoperative hospital stay was similar. I mean, this could be multifactorial. It is decided not just by the return of bowel function. Interestingly, we found the hemoglobin to be much lower. That was significantly lower in the conventional arm as compared to the goal-directed fluid therapy group, which was statistically significant. The remaining laboratory parameters were comparable between both the study groups. So what it means is that we found our results of lesser intraoperative fluids and faster bowel recovery in the PVI group or the goal-directed fluid therapy group was similar to those that is available in the adult literature. Just that we do not have, because the pediatric literature is so sparse, we do not have any other study to compare our results. but this is very encouraging that we could do with lesser fluids and achieve euvolemia in the PVI guided goal directed fluid therapy group. So that brings us to the advantage of incorporating dynamic indices into goal-directed fluid therapy, because it's more scientific. You have a definite endpoint, or you have at least an objective parameter to target to guide the fluid therapy. It is repeatable and reproducible because if somebody else is there, and you follow the same protocol, it's repeatable, and it is versus in a restrictive approach, which is the other approach when it comes to take care or to counter the effects of hypervolemia. It's always often a question as to how much to restrict, and how much do we restrict? Do we go with an arbitrary number, or for example, in the study by Ponde et al., they had used hemodynamic changes with base deficit to guide the administration of fluids. And here, when we use base deficit, it requires an arterial blood gas analysis to look at the base deficit. And there is always a lag time between obtaining those base deficit and administering the fluids. Now, when it comes to the fluid responsive indices in pediatrics, one thing that we should note is that what is available in the literature talks a lot about the pressure-based parameters, because that is what is most that is validated in adults and more widely used in the adult anesthesia world. The pulse pressure variation and the systolic pressure variations. But we must here understand that the blood vessel characteristics and compliance are different in children, because it's more distensible because of the less because there is more arterial wall thickness, and collagen fiber quantity is much more in the adult, so it is more stiff. The adult vasculature is much more stiff, so the pulse pressure variations and systolic pressure variations are validated in adults, and it is much more reliable, or it reflects the cardiorespiratory changes in the preload and the stroke volume much better than in the children. The other important factor to consider in pediatric dynamic indices of fluid responsiveness is the larger overall respiratory compliance in children. So which means that if there is a change in the intrathoracic pressure that is transmitted to the vascular system is less when for comparable tidal volume per weight. So when we look at pressure-based indices are not as good as it is, or it is not as well validated as in adults because of these changes. But what about flow-based indices? Like, for example, Plethysmographic Variability Index is a flow-based index because it does not depend on the pressure variations in the peripheral vasculature. And so we see that this meta-analysis of 4 studies which try to validate the PVI found a very reliable and good prediction with an area under the curve of 0.86, which is reasonably good predictor of fluid responsiveness in children. So here one must also understand, for example, what we found a higher values of PVI during the first hour of anesthesia, which kind of evened out in the second hour. And we presume it is because, PVI guided more fluids to be administered in the first hour, more boluses, and the supplemental boluses kind of replenish the volume without causing hypervolemia. And this could be, this also explains the reasoning for hemodilution with the conventional fluid regimen, because when we give fluids based on calculations, we tend to give them more fluids, the excessive fluids, more than that is required. So and that causes hemodilution. And we say it is because of it's probably because of hemodilution, because the blood loss as well as the blood transfusion was similar in both the groups, with higher volume of crystalloids in the conventional arm. Coming to critical appraisal, what are the strengths of what we did? Because it's kind of novel, because it's the first study which in our knowledge which evaluated a goal-directed fluid therapy in children. And we had studied in a very homogeneous cohort of children coming for elective bowel surgery. So it is better applicability in similar settings. However, we also understand and concede that there are limitations of applying PVI because PVI is validated only in mechanically ventilated patients. And a good number of pediatric anesthesia procedures happen in non-operating room locations where the children are ventilated spontaneously. So PVI may not be applicable in such situations. And then PVI, because it is based on a calculations from the plethysmography, there is usually a lag time of 2 to 3 minutes. So which means that, if the PVI number is high, we don't have to immediately take action and give fluids. We need to allow those lag time to settle, wait for about 3 to 5 minutes. And if it is consistently on the higher side, only then we need to increase the fluid infusion. Another limitation is that it's applicable only in closed chest procedures because it needs it depends on the intrathoracic pressure to be stable, and then the interactions between the increase in the intrathoracic pressure is very important. So it is applicable only in closed chest procedures. Then again, coming to its applicability in procedures with major blood loss or major fluid shifts is not yet studied, nor is it validated in such settings. And whether it is applicable when the patient goes prone is not known. Having accepted all those limitations, but what the study currently at this point of time, what this article or this study adds is that PVI guided goal-directed intraoperative fluid therapy significantly reduces the intravenous crystallars administered during pediatric bowel procedures, and such goal-directed fluid management results in faster recovery of bowel function and lesser hemodilution in the immediate postoperative period when compared to our conventional fluid therapy. How can it change practice? PVI can be a valuable tool to titrate intraoperative fluids, and it has a potential for regular use in major pediatric surgical procedures. GDFT can be incorporated or can be suggested to be incorporated into pediatric ERAS practice, which is currently missing in the pediatric ERAS guidelines. Thank you. Over to you, Vrushali.
Thank you, Preeti. Yes, indeed. Thank you, Preeti. That was absolutely clear. And thanks for the presentation. There are a couple of questions in the chat box. I would come to them. Anybody wants to ask a question, they are most welcome to raise their hands. Meanwhile, while Rosa is our officer in the WFSA who looks after the digital learning. She is going to guide you through asking the questions in person. So meanwhile, I would just start with the first question that I saw popping up in the chat was the dose of phenylephrine in pediatrics and why phenylephrine, if at all?
So the 0.5 microgram per kilogram was what we had incorporated in our protocol. Why phenylephrine? Because, there is always, if we are giving too much of fluids, there could be an element of vasodilatation because of the anesthesia. So we would want to, increase the systemic vascular resistance to restrict giving too much of fluids, because giving excessive fluids can also be deleterious. To increase, there's always a risk of pulmonary edema with giving too much of fluids. So we didn't want to just give fluids liberally, unlimited. So we wanted to incorporate vasoconstrictor therapy, and phenylephrine would be the best option to just achieve peripheral systemic vasoconstriction.
All right. Did you at all ever found anybody in pulmonary edema in the liberal arm?
No, we did not find anyone with pulmonary edema, nor did we have to use phenylephrine in any of our patients, either in the liberal group or in the PVI group.
Okay. Anybody wants to ask a question? Otherwise, I have a whole list and I can keep on asking.
Vrushali, also there is a question regarding the if any kidney injuries has been recorded during this study.
Yes.
Pardon me, I didn't get that question right.
They are asking that are there any kidney injuries, deficiencies during the study? Injury to the kidney?
No, we were tracking the creatinine pre-operatively as well as after the procedure. We did not encounter any rise in creatinine at the end of the procedure. And of course, as part of exclusion, we had not included patients with renal insufficiency, so they had to have a creatinine clearance of at least 90 mils per kilogram per minute.
Preeti, another question asked for you is how to monitor PVI. Is it accurate with arterial pressure monitor, pulse oximeter? What is your take?
So PVI stands for Plethysmographic Variability Index. So it is calculated from the plethysmography waveform, which is from the pulse oximeter. So there are monitors with those algorithms incorporated, which gives the PVI index. This is different from arterial pressure monitoring. In arterial pressure monitoring, if you have the software to look at the dynamic indices, one would look at the index called systolic pressure variation or pulse pressure variation. So these are two distinct entities, though the underlying principle is the same, just that, where those, the calculations and the algorithm come from is different, but the principle is the same. It depends on the cardiorespiratory interactions on the fluid status.
Oh, so what are the normal values? What is the normal range of PVIs?
So typically it is usually, if it's normal, if it's a normal volume status, it is typically less than 13%. But then there is also, like, if you look at the research paper, there is something called a gray zone concept, which means it's very difficult to say which is absolutely normal. So for example, if I say it is less than 13% is normal, but say suppose you have a patient with 14% of PVI and he could be a responder. Like, not everybody with 13% would respond to fluids, which means after giving fluids, it would come down to say 8 or 9. So there is this gray zone of, I think it's 14 plus minus 3 is the gray zone for PVI, which means if they're in the range of 10 to 15 approximately, they may or may not respond to a fluid bolus. So, I mean, but then I think, in our study protocol, we targeted less than 13, and we were not like, in case it was at 14, it's not that immediately we were going to give them a bolus. We would allow it to temper down and see the trend and make sure that it is, more than 13%. And we also had to combine it with the mean arterial pressure. So it is not just a standalone number that we are targeting. It has to be, factored into. That is why we call it goal-directed fluid therapy, guided by PVI. So we have to look at the clinical signs also when we decide on fluid management, on giving extra additional fluids. And PVI is just a tool to kind of make it more objective in titrating your fluids.
Yeah, and maybe the trend of what you get as a result of your actions by giving fluid probably would also give some direction as to where we are heading towards. When exactly was the post-op HB done?
The post-op HB was done at 24 hours after the procedure.
Okay. Another question asked is how to calculate PVI, if at all, or it is just that it is in the monitor, you said.
Typically, it is it comes as a number because it has to be averaged over respiratory cycles. So it's an average over, I think, 1 or 2 minutes. But the formula for it is that it is calculated from the pulsatility index of the plethysmography. So it is PI max minus PI minimum divided by PI max, and it is expressed as a percentage, so into 100.
Right. So for whosoever who has asked this question, probably it's easy to look at the pulse oximeter, I mean the monitor and understand the value rather calculating via the formula Preeti has just given you. There is a
I don't
formula.
think it is practically possible to calculate
Possible,
though, even if you
absolutely.
know that PI, because we need to take the average over time.
Yes, yes. And it's going to be a very dynamic situation, isn't it? As we give the fluids, as we correct the clinical situation. Well, one person is asking you, why have you chosen 5 ml per kilogram bolus and 25 ml per kilogram per hour?
So, I mean, when we started this, we didn't have anything to go by. Like, there was no previous study which looked at a goal-directed fluid therapy in the perioperative setting. All we had was to fall back on our sepsis guidelines, which said that, in the first hour, if somebody is acutely hypovolemic, you could give up to 20 ml per kilogram in 1 hour for the initial resuscitation. And then we thought we should give some time for it, to give the bolus, look at response, and not just give 20 mils in the first go. So we broke it up into, maybe 5 boluses in an hour. So it comes to about 4 ml. And then it's again more difficult to calculate 4 ml per. Its round number was 5 ml per kilogram as a bolus to be administered over 10 minutes. And during that infusion, we kind of see how the PVI settles down, how the MAP settles down. And if it persists to be, outside the desired range, then we give another bolus of 5 ml per kilogram. So typically isn't that how we work in anesthesia? We don't give large boluses, we give smaller boluses over a period of time, look at the trend, look at the response. So it was practically to simulate what we typically do in our operating rooms. So there is no major logic. It was just a practicality and, being gentle with fluids. But we limited it to 25 mils per kilogram so that, we have some number to limit. We didn't want to be administering excess fluids for those little ones who weigh just 10 kilogram on an average.
So, how were the bowel recovery assessed?
So,
is another question.
Yeah. So bowel recovery was either mostly by movement of bowel movement.
Which is peristalsis sound? Would you put
Yeah,
it that
bowel
way?
sounds, auscultation for bowel sounds, as well as, bowel movement.
Okay. If no epinephrine, if it was not phenylephrine, could you have used epinephrine or ephedrine? Is another question.
Yeah, I mean, I think, it's either phenylephrine or ephedrine are reasonable good choices.
Yes.
I would rather go for norepinephrine rather than epinephrine amongst the catecholamines, because which has got, our idea is to have a peripheral vasoconstriction, not so much for the inotropy. So I think it would be either phenylephrine or ephedrine or norepinephrine, not epinephrine.
All right. So is there any scale to evaluate the bowel recovery? Is a question here.
No, I mean, we did not use any scale. Because they were in the surgical post-operative room, and the surgeons were they were more concerned about bowel recovery, and then they would be auscultating them every 4 to 6 hours. So I think we went by that. Yeah.
Yes. So it was more of a surgical call.
Yeah, I mean, because the most of the adult literature talks about restrictive or goal-directed fluid therapy and a significant improvement in the bowel return. And we just wanted to check whether, it can be reproduced, or does it make sense in pediatric procedures.
All right. Aarti Sharma has raised her hand for a question. Aarti, could you please ask your question?
Yeah. Preeti, thank you for the wonderful paper. It's very unusual because we have so many papers in adult population, but we barely have anything in the pediatric. I just have 2 questions for you. One is, was your epidural standardized, the level? And the reason I ask is, higher the level of epidural, more vasodilation and drop in blood pressure you will get, and thereby you may end up using more fluids. The number 2 is interesting choice. I was wondering, you included PSARP, posterior anal rectoplasty. At my institution, it is done in prone position, and the incision is not that big and fluid losing. So were all this patient choice was equitable in volume loss?
I mean, I'll answer the first question first, about did we standardize the epidural level? So we used both caudal as well as lumbar epidural depending on the procedure. Typically for PSARP, we would have been giving a caudal, not a lumbar epidural catheters for them. And when it comes to requirement of fluids because of difference in caudal epidural or lumbar epidural, we know in pediatrics that there is not too much of a sympathetic blockade that
Yes.
comes in with pediatric epidurals. So that was not a big concern for us when we were doing the planning phase of the study. And then whether some of them, did we have more caudals in one group or more epidurals? That was similar across the groups. I agree that it would have been nicer if we could just standardize that too, that, do only procedures in which we used only caudal epidural or only lumbar epidural. But then, then it would have taken much longer for the study and our patients might potentially run out. So we wanted to kind of, make it comprehensive and look at, does it make any difference? So that's the best that we could standardize. Yeah, that was the first thing.
I'm very sorry I'm intervening because the time is premium and we're running short, but I'm sure Preeti and Aarti can actually rendezvous on the chat, as it were. Over to you, Serpil.
Thank you, Vrushali. It was excellent, and the discussion was going further and further because the topic is very interesting. I think Dr. Preeti can write on the chat box if she can answer the questions. Now we have Professor Hee-Suk Kim to present their paper on effect of tidal volume change on pressure-based prediction of fluid responsiveness in children. So thank you. Dr. Hee-Suk, floor is yours.
Thank you. Thank you for your kind introduction, Dr. Serpil. Hello, everyone. My name is Hee-Suk Kim. I'm a pediatric anesthesiologist at Seoul National University Children's Hospital. I'd like to begin by expressing my gratitude to the WFSA Pediatric Committee for inviting me to deliver this presentation. I'm truly honored and delighted to have the opportunity to present today. In the presentation, I will be reviewing key findings from a recent article and discussing practical implications for pediatric anesthesia. Let's dive in. Okay, before starting, I'd like to declare that I have no conflict of interest to disclose regarding this presentation. Here is the paper we will review today. The title is Effect of Tidal Volume Change on Pressure Based on Prediction of Fluid Responsiveness in Children. This is published in 2023 in Pediatric Anesthesia. Okay, let's review some key background facts. Assessment of volume status is important during the surgery. Hypotension in children can result from several factors, including preoperative fasting, fluid losses, surgical maneuvers, and vasodilation effect of anesthetics. And fluid management in children possess unique challenges. Overloading increases the risk of morbidity, systemic edema, and pulmonary complications, while hypovolemia leads to high organ hypoperfusion. Balancing these factors is critical for optimal outcomes in the pediatric population. Commonly used traditional parameters such as blood pressure and CVP provide only limited insights into the true volume status, especially in children. These static measurements alone are also insufficient for precise decision making. In contrast, dynamic parameters such as PPV, SPV, SVV, and of course PVI utilize the respiratory cycle variations to provide more reliable indicators of fluid responsiveness. In adults, dynamic parameters like PPV and SPV have been reliable tools for predicting fluid responsiveness in mechanically ventilated patients. Their predictive ability improves when tidal volume is increased. However, in children, the story is different. The unique physiological characteristics of pediatric patients often limit the accuracy of PPV and SPV for predicting fluid responsiveness. So, what are the more effective and reliable parameters for predicting the fluid responsiveness in children? One of the most reliable methods is delta V peak. That is measuring the respiratory variations in peak blood flow velocity at the aortic valve. And another promising parameter is PVI, which is already discussed in the first article, and using ultrasound to measure the respiratory variations in structures like ICA or IVC can also provide valuable data. As you know, PPV and SPV, which can be easily obtained from even the patient monitor, are widely used in adults. However, studies showed that they are often unreliable in pediatric patients, as the previous facts pointed out. So in this article, the researcher hypothesized that the augmented PPV or SPV due to increased tidal volume may predict the fluid responsiveness in children. This hypothesis can be tested by evaluating the stroke volume index with the TEE after fluid administration. This study involves children under 6 years old undergoing CPB for ASD, VSD, or combined defect. The patients were anesthetized with sevoflurane, midazolam, remifentanil, and rocuronium. Standard monitoring and continuous monitoring of arterial blood pressure and central venous pressure were done. TEE is used perioperatively to monitor cardiac function and assess the hemodynamic parameters, providing real-time insights into fluid responsiveness. Following the surgery, an alveolar recruitment maneuver is performed to optimize the respiratory function. The study protocol involves a sequential application of tidal volumes at 6, 14, and 10 milliliters per kilogram, each applied for 90 seconds, and no PIP. And after that, measure the PPV and SPV and CBP. The protocol utilized the delta V peak and SBI as primary indicators of fluid responsiveness. At a tidal volume of 10 milliliters per kilogram, delta V peak and SBI are measured using TEE. After administering 10 milliliters per kilogram of crystalloid fluid over 10 minutes, SVI is recalculated 1 minute after fluid challenge. The recalculated SVI values are obtained by averaging 3 measurements taken at the same probe location and angle. Patients are categorized based on their SVI response. Responders was defined that delta SVI increased more than 15% post-fluid challenge. To determine the predictability of fluid responsiveness, the study used the ROC analysis. The ROC curve analysis evaluates how well parameters like PPV, SPV, and CVP predict fluid responsiveness in responders at the different tidal volume level. This table shows the comparison of hemodynamic parameters before and after a fluid challenge in two groups at the tidal volume of 10 milliliter of kilogram of setting. After fluid challenge, heart rate, blood pressure, CVP, and peak airway pressure in responders and non-responders changed. Before fluid administration, there was no differences between responders and non-responders in all measurements. Of course, SPI and CI increased after fluid challenge in responders by responder definition. Well, let's examine the ROC curves provided in figures to evaluate the predictive power of various parameters for fluid responsiveness in different tidal volumes. At the tidal volume of 6 milliliter per kilogram, CVP has the AUC of 0.664, PPV was 0.679, and SPV was 0.655. Notably, delta V peak demonstrated that the highest predictability with the AUC of 0.8, significantly outperforming CVP, PPV, and SPV, a tidal volume of 10 milliliter per kilogram. At the higher tidal volume of 14 milliliter per kilogram, all parameters showed relatively lower predictive value, with the CVP, PPV, SPV having AUC values of 0.664, 0.576, and 548 respectively. This ROC curve analysis demonstrated that the delta V peak at the tidal volume of 10 milliliter per kilogram stands out as the most reliable predictor of fluid responsiveness. This table highlights the changes in parameters based on tidal volume adjustment. Most parameters measured in this study did not show the differences between responders and non-responders, regardless of tidal volume changes. Well, one of the key observations was that the PPV and SPV values increases as tidal volume increased. However, despite this trend, neither PPV nor SPV could reliably predict the fluid responsiveness regardless of tidal volume level. In contrast, delta V peak demonstrated significant predictive capability with an AURC of approximately 0.8 and a cutoff value of around 11. This makes delta V peak a more reliable parameter for assessing fluid responsiveness in children compared to PPV and SPV, as with the previous study results. Let's discuss why PPV and SPV underperformed as predictor in this study. A major reason might lie in the differences in arterial wall compliance between adults and children. Adults tend to have a reduced arterial compliance, making it easier to reflect changes in pressure caused by variations in tidal volume. On the other hand, children have higher arterial compliance, which dampens these pressure changes and reduces the sensitivity of PPV and SPV as indicators. Another contributing factor is the chest wall compliance. Pediatric patients have higher chest wall compliance compared to adults. This high compliance minimizes the intrathoracic pressure change induced by tidal volume, further limiting the effectiveness of PPV and SPV as predictor. This study has several limitations. First, one of the main limitations is related to ventricular wall compliance after weaning from CPB. Since our measurements were taken after CPB weaning, this increased compliance might have influenced the results, particularly in assessing the cardiac output and fluid responsiveness. Therefore, our findings should be interpreted with caution, considering that the myocardial condition may not be stable immediately after bypass. Secondly, our study included the patient with ASD, which may have affected the result. It is well known that in the patient with ASD and the left to right shunting, left ventricular compliance reduced due to chronic underloading. This reduced compliance could have contributed to the variations in hemodynamic measurements and may have acted as a confounding factors. Third, our study included a wide range of pediatric patients, from neonates to children up to 6 years old. Neonates and infants have different chest wall compliance compared to older children, which could have affected ventilatory or hemodynamic responses. Due to our small sample size, we could not perform subgroup analysis based on age or surgery types. Finally, there were methodological limitations in how we measured cardiac output and fluid responsiveness. We rely on TEE to measure SBI instead of thermodilution method, which is considered the most accurate technique for measuring the cardiac output. While TEE is a useful and non-invasive tool compared to the thermodilution technique, its accuracy can be limited in certain conditions. Now, let's discuss what this study contributes to the field. The researcher investigated whether increasing tidal volume up to 14 milliliter per kilogram could improve the predictive ability of PPV and SPV in children undergoing cardiac surgery. They found that while PPV and SPV values do increase as tidal volume increases, these parameters still fail to reliably predict the fluid responsiveness in children. On the other hand, delta V peak, which measures the respiratory variations in aortic blood flow peak velocity using TEE, was confirmed to be the most reliable parameter in pediatric patients. This reinforces the idea that unique factors in pediatric physiology, such as large chest wall compliance and ethic constraints on using larger tidal volume, likely limit the effectiveness of PPV and SPV in this population. So, unfortunately, the finding of this study did not lead to changes in our hospital's clinical practice because the augmented PPV and SPV with the increased tidal volume could not predict the fluid responsiveness in cardiac surgery. Nevertheless, our research team has gained momentum to continue to pursue of better fluid responsiveness parameters. Thank you for your attention. I hope this session provides valuable insight into fluid strategy for pediatric anesthesia. I welcome any questions and thoughts you may have. Thank you.
Thank you, Hulusi Kim. I believe wholeheartedly that your research team will find many research and solutions for this regarding fluid responsiveness in pediatric patients, because you have lots of papers on this, the team. Now, since we have very strict in time, there are some questions for you. One is tidal volume has 10 milliliters per kilogram. Because of it, could thoracic pressure increase to affect the fluid responsiveness?
Sorry, I don't understand you. 10?
Because of tidal volume, it's 10
Uh-huh.
milliliters per kilogram.
Yes, yes.
It affects the thoracic pressure it makes increase to affect the fluid responsiveness.
It's
Can
10
it
milliliter
affect
per
the,
kilo.
yes. Does
10,
it
yes.
affect the fluid responsiveness?
Yes, even we usually use the low tidal volume strategy in our institute. So the 10 is actually is a relatively large tidal volume, even though even though the tidal volume is 10 milliliter per kilogram, there is no predictive the PPV or SPV does not give any information for the further responsiveness in this patient.
Okay, thank you. And also they asked that how did you replace for blood loss? Did you
The blood loss. Okay,
Mhm.
it's a cardiac surgery. So blood loss is there. We have an institutional guideline for the cardiac surgery. So we just follow that. Only the blood loss is follow that protocol.
Hmm.
Yes, it would be around 10 milliliter per kilogram per usual.
per usual?
Yes.
Thank you. Are there any questions who can raise? You can raise your hands also to ask questions. And also there are people thanking you for the great presentation.
Thank you.
Any questions?
Serpil, there is one question here. What was the plane you apply when calculating through TEE?
Sorry?
The plane you apply when calculating TE, transesophageal echography.
Calculation is actually is on the paper.
No. What
Okay.
was the plane? What was the plane you apply?
Long axis plane.
Correct.
Yes.
Okay.
Long
Is it-
axis plane.
Okay. And one more question, is it safe to deliver 14 ml kilogram tidal volume to augment PPV, SPV, considering lung protective ventilation strategy?
Yes, right. Yes, that is good point. Yes, yeah, yes. It was actually it's a dilemma for us because even though 10 milliliter per kilogram is a little bit larger for us, for the children. So, but even though for the adult, the 12 or 13 is permissible. So the 14 is just the larger, the larger than the adult limit of tidal volume. So if we tried we tried to 12, but the limit the interval is too small, 10 to 12. So that's why we choose the 14. But actually, yeah, it's an ethic problem. It would be, yes. Thank you.
There's another question
So
regarding lung injury. Using high tidal volumes, does it increase the lung injury? Any relationship with PEEP, PEEP? They are asking.
Yes. Well, it's usually we use the low tidal volume with the high PEEP in the cardiac surgery. So we just applied 90 seconds just just very short time and reduce the tidal volume to the 10 or 88.
Okay, thank you, thank you. Any more questions I missed, Vrushali? There's one more coming. Do you start calculations after weaning bypass or after chest closure?
Chest closure, after chest closure.
After chest closure. Are you calculating tidal volume by lean body or any body weight?
No, body surface area.
Body surface area.
Yes, divided by the surface area. Yes.
I think no more questions. Did I miss some more questions, Vrushali?
No, not that I can see.
Okay.
And the topic is so specific and so super specialty topic actually, cardiac anesthesia and fluids.
Yes, right.
It's interesting.
Okay, so it was really interesting to have our speakers and their studies to discuss about it, but time is so restricted. So we have come to the end of this enlightening journal club. We all want to extend our heartfelt gratitude to all of you for your invaluable participation in today's journal club, which we had started today. It has truly been a privilege to engage with such a dedicated group of professionals in pediatric anesthesia. We have had the distinct honor of hearing from such distinguished speakers, Mrs. Hisu, Professor Hisu, and Ms. Professor Prethi, who have each presented exceptional studies on their critical topic of the management of fluid management in pediatric anesthesia. Their research has not only enriched our understanding, but also illuminated exciting new perspectives and may open to way to some more research on the management and care of our pediatric patients. And the insights shared today remind us of ever-evolving nature of our field and the importance of learning from each other. The challenges we face require innovative solutions as demonstrated by our speakers. We need collaboration and knowledge sharing as they did today. As we reflect on the rich discussions we have had, let us remember that the future of pediatric anesthesia hinges on our commitment to continuous education and advancement. The approach we explored today will pave way for improved outcomes in our young patients, helping us navigate for the complexities of their unique needs and greater confidence and competence. And also, I would like to take this opportunity to invite you to the World Congress of Anesthesiologists, which will be in 2026, which will be held in vibrant and picturesque Morocco. This event promises to be a remarkable gathering of events, experts, where we will explore a myriad of compelling topics and have the chance to meet and reconnect with old friends and colleagues. Such gatherings not only broaden our horizons, but also strengthen the global network of professionals dedicated to advancing the field of anesthesia and opens way to more research on this field. So, Vrushali, floor is yours. Thank you.
Yes, thank you. Did you note Serpil said we are evolving and we shall. So this is a very small way and the perfect way how nature has worked through, and we are here exactly for that, and that's how we would keep on. So here you go, and thank you very much for being here. And with this, happy goodbye to all of you, and we see you in our next webinar in Journal Club. A big thank you.
Thank you.
Thank you, Hisu. Thank you,
Thank
Preeti.
you.
Thank you.
Rosa.
Thank you. Thank you, all of
so
you.
much. And thank you all the listeners. Thank you so much.